This hearing will come to order. Let me begin by saying generally hearings do begin a bit later, but because we felt the urgency of this matter, we had to take the only time available so that we can vacate for another previously scheduled hearing. So I appreciate all of you coming early this morning, and thank you for joining and this meeting, as I mentioned, will officially come to order. And thank you for joining the subcommittee this morning on Africa and Global Health for this hearing entitled Global Health Emergencies Hit Home, the Swine Flu Outbreak. The recent outbreak of a new strain of Influenza A subtype H1N1 virus, commonly referred to as swine flu, sparked significant global concern and attention, and reminds us that global health challenges are challenges to the health of our own nation and the entire international community. We truly live in a global village, and it is no more apparent than it is today. Indeed, to date, our own hemisphere is most affected. The first identified cases occurred in Mexico in March, where 590 cases and 25 deaths had been reported, followed by 286 cases and 1 death in the United States, and 140 cases and 0 deaths in Canada. On April 29th, the World Health Organization raised its influenza pandemic alert to level 5, a strong signal that a pandemic is imminent. Many questions remain as to the exact origin of the virus strain, and while it contains genetic material from flu strains usually found in swine, pigs have not yet been identified as a source of human transmission. The association with pigs could be injurious to the swine industry, and there has been a request that members of Congress refer to the strain by one of its technical terms. There are many issues associated with this H1N1 virus strain. The WHO Phase 5 alert carries with it a series of public health measures that countries are expected to adopt to avert a crisis. Among other issues this hearing will focus on is how global health emergencies such as this one challenge the public health infrastructures of developing nations. And we hope to learn more about the assistance that the United States is providing to address this worldwide weakness. While no cases have been confirmed to date in African countries, I am concerned that the lack of reported cases of H1N1 in Africa may actually represent the absence of the ability to detect the virus strain, which could mean that the true impact of this strain is yet to be seen. Adding to concerns, there have been several recent deaths in Southeast Asia and Africa caused by the avian flu. These issues underscore the need for greater investment in health systems in Africa in particular and in other developing regions. We will also discuss funding. As you know, the 2009 supplemental appropriations include $2 billion to fight pandemic flu, $1.5 billion which goes to Health and Human Services and Centers for Disease Control for federal stockpiles, vaccines, and detections. Of the remaining funding, $350 million goes towards state and local response and $200 million for global efforts. President Obama has shown incredible leadership on global health this week, just yesterday announcing $63 billion to be spent over the next 6 years, starting in fiscal year 2010, shaped by a new comprehensive global health strategy. Under President Obama's new plan, $51 billion will go towards fighting HIV, AIDS, tuberculosis, and malaria through the President's Emergency Plan for AIDS Relief, as we all know as PEPFAR. The remaining $12 billion will go towards other global health priorities, such as child and maternal health, neglected tropical diseases, and an overall investment in building capacity of health systems. And this is something that African nations have said this is what we really need as we get this assistance to deal with the health crisis. We need to be able to build a health system, and that is what we will concentrate on. So when the need for overall assistance from the U.S. Dissipates, the health systems will be in place. I commend the President for this quantum leap in global health funding. It shows the United States understands global health challenges and what we must do because these challenges can hit us here at home, as well as we have seen in the outbreak of H1N1 virus. And as we may recall, in 2007, the case of the Atlanta lawyer, Andrew Speaker, who traveled to Europe and back to the United States, all while infected with the deadly, extensively drug-resistant tuberculosis strain known as HDR-TB. There is also a geopolitical dimension to the H1N1 outbreak. The World Health Organization cautions that those who are ill should delay international travel. However, warns that limiting travel and imposing travel restrictions would have very little effect on stopping the virus from spreading, but also would be highly disruptive to the global community. Despite this warning, China has reportedly quarantined a number of Mexican nationals living in China. Mexico's response to this was a ban on flights to China. Last week, the European Union Health Commissioner urged Europeans to avoid non-essential travel to the United States and Mexico following the confirmation of a case of the H1N1 virus in Spain. U.S. Homeland Security Secretary Janet Napolitano explained in a Senate Homeland Security Committee hearing last Thursday that closing the U.S.-Mexican border would incur more cost than benefits to the United States government's effort to stop the spread of the virus. I am sure these and other issues will allow us to have an in-depth discussion on this important topic. So we're pleased today to be joined by our distinguished panel of government witnesses. First, we will hear from Dr. Ann Schuchat, the Interim Deputy Director for Science and Public Health Program at the Center for Disease Control and Prevention. Our second witness is a longtime friend, Dr. Anthony Fauci, Director of the National Institute of Allergies and Infectious Diseases at the National Institute of Health. And last but not least, a longtime associate also, Dr. Dennis Carroll, who serves as Special Advisor to the Acting Administrator on Influenza Pandemic at USAID. And we'll go through the bios after we hear remarks from other members. And at this time, I'll turn to my colleague from New Jersey, the ranking member, Mr. Smith, for his opening statement.
Thank you very much, Mr. Chairman, for calling this very important hearing on the issue of the recent outbreak of the H1N1 influenza. I'm particularly appreciative that our witnesses have taken the time to be with us this morning, as they are extremely busy addressing the current situation in their respective agencies. And thank you for your tremendous service on behalf of all those who potentially could become sick, as well as those who are. In its latest update, the World Health Organization has indicated that 22 countries have officially reported 1,516 cases of the influenza, including 30 deaths, 29 in Mexico. This count does not include the death of the first United States resident that is being reported this morning. Despite that tragic news, it seems that, in general, the virus within the United States is no more infectious or deadly than the seasonal flu. It is still uncertain as to why Mexico experienced so many deaths from the swine flu, and cases in the United States have been relatively mild. In any event, experts are warning that we must remain vigilant and take prudent precautions until more is known about the virus, and there is concern that a more dangerous reemergence of it could occur in the fall. Our country has benefited from procedures set in place during the Bush administration to respond to such a potential crisis. President Bush implemented the National Pandemic Strategy in 2005 and the Domestic Readiness Group, a broad interagency panel, which he established to respond to national emergencies and has been active from the beginning of the outbreak. We have been fortunate to have a well-developed system in place for the new administration to utilize, and they have done so well. However, despite these efforts that have apparently served us well so far, some experts are asserting that we needed to be doing even more to prepare for likely pandemics. The National Biosurveillance Advisory Subcommittee that was created by a presidential directive in 2008 is expected to release its first report soon. Dr. Larry Brilliant, chairman of that subcommittee, stated in an article published in last weekend's Wall Street Journal that the report concludes that our country and the world do not have adequately early warning biosurveillance capabilities. The NBA subcommittee will be recommending that, quote, governments need far better early warning systems for potential pandemics and other epidemic threats, close quote. Dr. Brilliant added that the subcommittee is also emphasizing that public health be restored to a position of respect and be given resources commensurate with its duty to protect us from these and other threats to our health. I look forward to hearing from our witnesses whether they agree with this recommendation, and if so, whether they have concrete ideas as to what actions our government should undertake to address it. Mr. Chairman, the Global Health Initiative announced yesterday by President Barack Obama could be an early and timely response to this recommendation by the National Biosurveillance Advisory Subcommittee. In his announcement, President Obama referred to the outbreak of the H1N1 virus and the need to address public health challenges beyond our borders. The additional resources he is proposing could prove extremely useful to help save lives as we all become more aware of the importance of addressing health threats not only within our own borders but around the world. However, the President emphasized that his initiative will be pursuing a, quote, integrated approach to global health, and the administration has indicated that reproductive health is high on its list of priorities. Therefore, this new initiative must be assessed in the context of the statements made by Secretary of State Hillary Clinton during a Foreign Affairs Committee 2 weeks ago that this administration's definition of reproductive health also includes access to abortion. I would note with extreme concern that this announcement follows the President's rescission of the Mexico City policy that prevented taxpayer monies from going to foreign non-governmental organizations that perform and promote abortion as a method of family planning. As you know, Mr. Chairman, the bipartisan support that resulted in the passage of the Tom Lantos, Henry J. Hyde U.S. Global Leadership Act against HIV/AIDS, tuberculosis, and malaria last year was a result of a consensus that rejected references to the integration and other linkages of reproductive health services with HIV/AIDS and malaria programs. Any attempt by this Congress or the new administration to break that consensus and to direct billions of dollars to organizations that kill unborn babies by way of chemical poisoning or dismemberment and wounding their mothers, instead of to organizations and programs that will save lives and improve the health of all children, born or unborn, women and men, will destroy that consensus. President Obama and his administration should be working to galvanize bipartisan political support to address the major global health challenges of our time, not to channel money to groups that seek to destroy the most vulnerable, the unborn child. I look forward to learning more from the administration as to how they will address this sensitive and extremely important human rights issue. The human rights of the unborn is the human rights issue of our day, and I believe passionately that the most persecuted minority in our world today are unborn children. In his brilliant article, Dr. Brilliant also describes his participation in the eradication of smallpox and the importance of pursuing public health initiatives to prevent or end other health threats. Early in my tenure in Congress, I had personal experience of both the importance and the possibility of making public health a priority in even the most difficult circumstances. During the FMLN conflict in El Salvador in the early 1980s, I visited on several occasions vaccination sites sponsored by UNICEF and the United States, during which days of tranquility were agreed to by both fighting factions. For 3 days, the fighting stopped on one of those occasions so that upwards of 250,000 children could be vaccinated against polio, measles, diphtheria, tetanus, and whooping cough. Since then, days of tranquility have been implemented in other countries, including Lebanon, Sudan, Iraq, and Sierra Leone. This experience impressed upon me the public can be galvanized when people realize that the goal is to save the health and life of children. I'm sure the same public will exist to address major health hazards that threaten our global community as a whole. It's extremely important for those of us in Congress to understand the health threats that face our world, including this new virus, and the possible means of preventing or eradicating them. And again, I thank you, Mr. Chairman, and again, I welcome our distinguished witnesses.
Thank you very much. At this time, we will hear from our members. Ms. Woolsey, for opening statement.
Thank you, Mr. Chairman. If everybody else would waive their opening statements, I will, because we have a 10 o'clock markup, and these nice people have been sitting here.
Thank you. Dr. Boltzmann. All right. Thank you. Ms. Lee, thank you. Ms. Jackson Lee, do you waive your opening statement?
Mr. Chairman, I will have to leave for a markup as well, so I'll just simply say that because the 2 deaths in the United States were in Texas, let me thank the witnesses for the face they've put on this cause. I do think we have a pending pandemic, and I want to thank the chairman for holding this hearing, and I hope to be able to engage with all of you as witnesses. Thank you very much. I yield back.
Thank you very much. We have a very distinguished panel today, and we will hear from them, Dr. Schuchat, Dr. Fauci, and Dr. Carroll. First, Dr. Ann Schuchat, the Interim Deputy Director for Science and Public Health Program, has been at CDC since 1988, when she entered the U.S. Public Health Service as an Epidemic Intelligence Service officer. She has made significant contributions to prevent infectious diseases in children through her work informing vaccine and prevention policies, developing guidelines and disease monitoring systems, conducting pre- and post-licensure vaccine evaluations, and collaborating with international, national, and state partners to accelerate the availability of vaccine and prevention programs. Internationally, she has worked in West Africa on meningitis and pneumonia vaccine studies, in South Africa on surveillance and prevention projects, and in China on SARS emergency. Dr. Schuchat graduated with highest honors from Swarthmore College and with honors from Dartmouth Medical School. She completed residency training in internal medicine at New York University's Manhattan VA Hospital. She's co-authored more than 180 scientific articles and received numerous awards, including the Public Health Services Meritorious Service Medal and the Physician's Research Officer of the Year for her contributions to preventing Group B Streptococcus infections in newborns. Dr. Schuchat assumed leadership of CDC's National Center for Immunization and Respiratory Diseases. In 2006, she was promoted to the rank of Assistant Surgeon General within the U.S. Public Health Service, and in 2008, she was elected to the Institute of Medicine. In February 2009, she began a detail serving as CDC's Deputy Director for Science and Public Health Program. Next, we have Dr. Anthony Fauci, who has been the Director of National Institute of Allergy and Infectious Diseases, NIAID, since 1984, and came to the National Institutes of Health in 1968. In his position, he oversees an extensive research portfolio on basic and applied research to prevent, diagnose, and treat infectious diseases such as HIV and AIDS and other sexually transmitted infections, influenza, tuberculosis, malaria, and illnesses from potential agents of bioterrorism. NIAID also supports research on transplantation and immune-related illnesses, including autoimmune disorders, asthma, and allergies. Dr. Fauci serves as one of the key advisors to the White House and the Department of Health and Human Services on global AIDS issues and on initiatives to bolster medical and public health preparedness against emerging infectious diseases such as pandemic influenza. Dr. Fauci received his MD degree from Cornell University Medical College in 1966, completed his residency at the New York Hospital Cornell Medical Center. Dr. Fauci has made many contributions to basic and clinical research on pathogenic and treatment immunized-mediated and infectious diseases. He has pioneered the field of human immunoregulation by making a number of scientific observations that served as the basis for a current understanding of the regulations of the human immune response. In addition, Dr. Fauci is widely recognized for delineating the precise mechanism whereby immunosuppressive agents modulate the human immune response. I'm going to end up being a doctor. Dr. Fauci is a recipient of many awards, including the Presidential Medal of Freedom, which is very prestigious, and 34 honorary doctorate degrees from universities. Finally, testifying on behalf of USAID is Dr. Dennis Carroll, who is a special advisor for the United States Agency for International Development's acting administrator on pandemic influenza. He has served as director of the USAID's Avian and Pandemic Influenza Preparedness and Response Unit, which oversees the agency's response to avian and pandemic influenza. From 1991 to 2005, Dr. Carroll served as the Senior Infectious Disease Advisor for USAID and was responsible for providing strategic and operational leadership for USAID's infectious disease program. Dr. Carroll has a PhD in molecular biochemistry from the University of Massachusetts at Amherst with a specialized focus on tropical infectious diseases. He was a research scientist at Cold Spring Harbor Laboratory where he studied the molecular mechanisms of viral infections. At this time now I'll turn to our first witness, Dr. Schuchat.
Good morning, Chairman Payne, Ranking Member Smith, and other distinguished members of the subcommittee. I'm Dr. Ann Schuchat, the Acting Deputy Director for Science and Program at the Centers for Disease Control and Prevention, and I appreciate the opportunity to speak with you this morning about the current outbreak of a novel H1N1 influenza virus, and to focus on the global implications of the outbreak and the steps being taken by CDC and our global partners to mitigate this problem. We share the concern of people around the U.S. and the globe, and particularly those in Texas, who have been impacted by this outbreak and are responding aggressively at the international, federal, state, and local level to understand the complexities of this situation and to implement control measures. Our aggressive actions are possible in many respects because of investments and support of the Congress in U.S. pandemic preparedness, which has provided us with many of the tools we're using today to detect, track, and control the outbreak and its impact. This support has also enabled the critical work of state and local public health officials across the country. In a global context, the work of the committee in promoting global health through programs such as PEPFAR and the President's Malaria Initiative have been critical to improving the capacity of health systems that will be relied upon with this outbreak. Once again, we're reminded that global public health is inextricably linked with the health of the American people, and that investments in global health have a direct benefit to our own health. I have noted in the written statement some of the important investments we've made in global pandemic preparedness, in global disease detection, and the remarkable international collaborations taking place to address the threat from this new virus. In summary, without these global mechanisms to detect disease, share information across the globe, and cooperate on response, we would not be able to mount the effective response we've carried out to date. Influenza viruses are extremely unpredictable, making it hard to anticipate the course of this outbreak with any certainty. We have seen an increase in the number of cases and the number of states and the countries affected, and we expect more. We are carefully monitoring the severity of illness caused by this virus. While the preliminary evidence as of today is encouraging, we understand that this too could change. Amid this uncertainty, we hope to be clear in communicating what we do know, acknowledge the uncertainties, clearly communicate what we are doing to protect the health of Americans and people around the world, and help people understand the steps that they can take to protect their own health and that of their families and their communities. As we look to the future, we'll be looking carefully and are already providing assistance to countries in the Southern Hemisphere, where influenza season is now beginning, both to help them respond and to examine clues about the direction that this epidemic will take. Unfortunately, as with many public health problems, lack of infrastructure and resources mean developing countries in particular can expect to bear a significant burden in this epidemic, and we hope to provide assistance to mitigate the impact that the epidemic may have. Influenza arises from a variety of sources, and in this case, we've determined that we have a novel 2009 H1N1 virus circulating around the globe that contains genetic pieces from 4 different virus sources. We've been able to move within 2 short weeks to identify this novel virus, understand the complete genetic characteristics, and compare the genetic composition of specimens from U.S. patients to others around the globe to watch for mutations. We've also, with unprecedented speed, developed and deployed test kits for use in a widening network of laboratories, both here in the United States and around the world. These steps, along with capacity in place as a result of effective planning, have allowed for the rapid diagnostics and epidemiology that have contributed to a clearer understanding of the transmission and the current severity of illness caused by the virus. These scientific accomplishments have provided the basis for an evolving set of responses that greatly enhance our nation's ability to address this threat. CDC has determined that this virus is contagious. It's spreading from human to human, similarly to the way that seasonal influenza spreads through coughing or sneezing. Sometimes people may become infected by touching something with a flu virus on it and then touching their mouth or nose. There's no evidence to suggest that this virus has been found in swine in the U.S., and there have been no illnesses attributed to eating pork or pork products. So there's no evidence you can get this influenza from eating pork or pork products. As of this morning, according to the World Health Organization, a total of 1,516 cases have been confirmed in 22 countries, including Guatemala, which was added to the list today. Here in the U.S., we have 403 confirmed cases and 702 probable cases for a total of 1,105. Aggressive actions are being taken here as well as abroad. We're working very closely with state and local health officials around the U.S. to investigate and implement control measures. We're providing both technical support on the epidemiology as well as laboratory support for confirming cases. We're working with our international partners on this outbreak, including a collaborative effort in Mexico to better understand the outbreak, to enhance surveillance and strengthen laboratory capacity, and we're working closely with multiple federal partners to ensure that our efforts are coordinated and effective. Yesterday, we updated our guidance on school closings based on a more clear understanding of the severity of illness. A key message we have from CDC is that there's a role for everyone to play during an outbreak. At the individual level, for people to understand how they can prevent respiratory infections with frequent hand washing, staying home if you're sick, keeping your children home if they're sick, and if you're ill, not getting on an airplane or taking public transport where you may spread the infection. We think that personal responsibility for these things will help reduce the spread of this new virus as well as other respiratory illnesses. The path this outbreak may take may change, and we need to be prepared for a return of this virus here in the U.S. in the fall. It's important that public officials continue to think about what might be needed if this outbreak deepens in communities here in the U.S. We've encouraged communities, businesses, schools, and local governments to make specific plans for how to manage this outbreak if cases appear in their communities, and advised parents to prepare for what they would do in terms of their own children's illness. We continually monitor the path and severity of the outbreak and have adapted our guidance accordingly, as we did yesterday with our change in the school guidance. We're mindful that science is a critical component in decision-making about how communities respond, and that there are many other considerations that communities must evaluate in making appropriate decisions. Whenever we see a novel strain of influenza, we begin to work toward the development of a vaccine in case one will need to be produced. CDC is working to develop a vaccine seed strain specific to this novel virus, the first step in manufacturing. We have initiated steps so that should we need to manufacture a vaccine in terms of the U.S. government's role, we can work towards that goal very quickly. And rapid progress will be possible through the combined efforts of CDC, NIH, FDA, BARDA, and the manufacturers. Another critical component of our response has been our deployment of the Strategic National Stockpile of medications and personal protective equipment. Finally, it's important to recognize that with the strong support of the Congress, there have been enormous efforts in the U.S. to prepare for this kind of an outbreak and a pandemic. Our detection of this strain in the U.S. came as a result of that investment, and our enhanced surveillance and laboratory capacity are critical to understanding and mitigating the threat. The investments made in global health and development will prove crucial pieces of the global health system that will be needed to respond. While we must remain vigilant throughout this and subsequent outbreaks, it's important to note that at no time in our history have we been more prepared to face this kind of challenge. And as we face the challenge in the weeks ahead, we look forward to working closely with you in the committee and Congress in general to best address this evolving situation. Thank you.
Thank you very much, Dr. Fauci.
Thank you very much, Mr. Chairman, Ranking Member Smith, members of the committee. Thank you for calling this hearing, and thank you for giving me the opportunity to briefly describe for you today the role of the NIH's research efforts in addressing the problem that we are facing now with the H1N1 new novel influenza A. On this first visual, I'd first to just take a brief moment to describe the difference between what we call seasonal flu and pandemic flu. As you see on this visual, the influenza virus is made up of a number of components. We identify influenza by two proteins on its surface called hemagglutinin and neuraminidase, and hence the terminology H and N, and the designation here of H1N1 and seasonal flus that also have H3N2. Each year, we have a relatively predictable annual occurrence of seasonal flu that from one year to another may modify slightly in what we call a drift, a little bit different from one year to another, which necessitates sometimes a modification of our seasonal influenza program for vaccination. However, it doesn't change enough to leave the population vulnerable with no background immunity. Rarely, in the last century, 3 times, we have a major change, which we refer to as a shift. And in this situation, this is unpredictable, and the population is naive to this particular virus because they've never had any personal experience with it. That is the case that we're facing now with H1N1. But before we go on, it's important to put into context seasonal influenza, which is underappreciated as a serious issue, with 36,000 deaths each year in the United States and about 200,000 excess hospitalization and significant economic impact. The concern we all have is that will this turn into a pandemic? So if you look on this slide here, there were 3 historic pandemics in the 20th century. One which was catastrophic, the 1918, what we call Spanish flu, in which about 50 million people died worldwide. In 1957 was another new virus that was moderately severe, and in 1968 was the first time we saw the H3N2, which in fact was relatively mild in the sense if it wasn't significantly different than what we see in a regular seasonal flu. So the point to be made is that pandemics occur for sure, but they vary widely in their degree of severity. So now quickly moving on, what about the NIH and what we're doing in partnership with our sister agencies, the CDC and the FDA, our responsibility that of the basic and clinical research. As shown in this slide, What we do is founded in a basic research study and research resources which we make available to the academic research community and the pharmaceutical companies. We have clinical research networks that allow for clinical trials, all of which is directed to the ultimate goal of developing countermeasures in the form of therapeutics, diagnostics, and vaccines. So quickly, we'll start with basic research. The CDC, as you've heard from Dr. Schuchat, has already isolated and characterized the virus and made it available to the NIH, as well as to giving us the opportunity to make this available to our grantees and contractors to study intensively. And when we say study intensively, we do sophisticated work on delineated the molecular analysis or the molecular fingerprints that might predict which way this virus may go, because as you've heard, it is quite unpredictable. Studies on transmissibility in animal models such as the mouse, the ferret, and the non-human primate, how the virus might molecularly evolve, and importantly, its pathogenesis and virulence. What are the molecular correlates for it being a very virulent virus or not? And finally, relevant to vaccine development, what kind of immune response does it elicit, and what kind of immune response is protective? On the next visual, you see the map of the United States showing the network of treatment and vaccine and treatment evaluation units, which will be used in the clinical trial of pilot lots that will be made from the seed viruses that the CDC is now growing in preparation for the multi-step process of developing a vaccine, which is shown on this next slide. It is a very well delineated process that we go through when we develop a vaccine for any microbe, in this case, influenza. First, you get the virus. The CDC has done that. You start to grow it up in what we call a reference strain or a seed virus. This allows the further growth, and in this case, we get that seed virus, which is currently now being grown by the CDC and will be made available to the pharmaceutical companies to grow up for what we call pilot lots. A pilot lot is tested in humans for three things. Is it safe? Does it induce an immune response that you would predict would be protective? And thirdly, what is the right dose and dose regimen? How many doses will you need? The decision to scale up and manufacture tens of millions of doses has not been made at this point, nor has any decision been made regarding the administration. We are just in the early part of the stepwise process of developing a vaccine. And on this final slide, I just want to reiterate what we said in the very beginning. The relationship between the preparedness of seasonal influenza versus pandemic influenza. What we learn from one, we apply to the other, and vice versa. We had a pandemic plan from 2005, which we've implemented, and the resources that have been put in, thanks to the Congress and your support for us, have allowed us to be at the level of preparedness which we are right now. Thank you very much. I'd be happy to answer questions after. Thank you.
Thank you very much. Now, Dr. Carroll.
Chairman Payne, Representative Smith, and other distinguished members of the subcommittee. First off, I'd like to thank you for convening this committee. I think we all appreciate its significance and certainly the topic which brings us here today. But I would also like to extend the thanks of AID to this committee for the strong support you have provided over the years to our global health program. In my written comments, I discuss at some length AID's response to the recent events in Mexico as part of the larger effort by the United States government. In these remarks today, I would like to focus more specifically on two aspects of AID's overall effort to address the threats posed by a pandemic, with a particular focus on AID's primary responsibility as the international response and humanitarian assistance role that we have. AID has been helping to prepare for just such an event, as we've seen roll out over the last several weeks, over the past 3 years. And as previous talkers have referred to the efforts underway having to do with H5N1, avian influenza, work that we have been doing since 2005, specifically supported by this Congress, have really established a platform which has allowed significant capabilities that otherwise had not previously been available. What I'd like to do is to just talk about some of those capabilities today and how they may play themselves out in the coming months. First off, in terms of a pandemic preparedness program focusing on global response capabilities. AID has partnered through a UN family of agencies, the International Federation of Red Cross and Red Crescent Societies, and a coalition of humanitarian response non-governmental organizations to work with WHO, our colleagues at Centers for Disease Control, and other international partners to focus on 30 countries in Asia, Africa, and Latin America that have been specifically identified as countries of high risk consequences in terms of a potential pandemic. And with these countries, we have been working to mobilize pandemic preparedness planning. Whereas coordinated efforts to respond to disasters such as pandemics usually begin only after the disaster has occurred, the concerns of a global pandemic caused by avian influenza created an unprecedented opportunity to develop planning and coordination for a pandemic in advance of the event. Because of this work, developing countries' ability to respond to a pandemic today, while still far from perfect, will be both better and faster than it otherwise would have been possible in years past. While the world remains at phase 5, AID is engaged in several critical activities to help monitor the progress of the H1N1 novel virus and assist countries in preparing for a possible phase 6 pandemic. These activities include testing the appropriate of national pandemic plans. Just last week, AID supported a regional pandemic readiness exercise as part of our avian and pandemic preparedness program in Addis Ababa, Ethiopia. Country representatives from 7 East African countries were able to draw from their experiences developing national pandemic plans to test them in real-time context of a possible H1N1 pandemic. We have similar exercises already planned for South African countries in June and Asian countries in August. In addition, AID is working closely with the Department of Defense and its Pacific and African combatant commands, PACOM and AFRICOM, to provide direct military-to-military assistance in these 30 countries across Africa and Asia to strengthen their own readiness, the readiness of the military to work in concert with civilian authorities to ensure the military is fully prepared and capable of executing their responsibilities during a pandemic. And in just 2 weeks, as part of AID's pandemic preparedness program, AID will co-host with AFRICOM and PACOM and the UN's World Food Program a joint pandemic preparedness exercise in Rome involving 27 countries and their military representatives from Africa and Asia. AID will also continue to support activities that directly contribute to tackling the circulation of the novel H1N1 virus in both human and swine populations worldwide. As noted by President Obama, even if it turns out that the H1N1 virus is relatively mild in the front end, it could come back in a more virulent form during the actual flu season. It is important to note that in the 1918-1919 influenza pandemic, which also began, the virus emerged first in the spring, relatively mild, for 6 months, until the second pandemic wave arrived in a much more lethal version that October. With the advent of influenza season in the southern hemisphere now, it will be critical that we are able to monitor changes in the virus's virulence and transmissibility and mobilize effective response should it occur. AID has also, as part of its avian and pandemic influenza program, which we have now adapted to our H1N1 novel virus response, established an emergency stockpile of more than 800,000 personal protective equipment kits, PPEs, that include protective gowns, gloves, goggles, and masks. 100,000 of which were just this past Saturday arrived in Mexico City. The remaining being equivalently ready for rapid deployment as needed. These kits protect healthcare providers as well as case investigators. To date, AID has also pre-positioned an additional 400,000 kits in 82 countries for use in the event of a pandemic. But even as we mobilize to respond to the threat of H1N1 or the earlier emergence of the H5N1 avian influenza virus, it is important that we appreciate that their emergence is indicative of a broader dynamic that over the past half-century has given rise to a steady stream of new and increasingly deadly diseases that originate in animals. In fact, 75% of all new emergent diseases that have emerged in the past 50 years, their origin are animal. Having already identified this rising threat as a major new area of focus, AID coincidentally announced last Wednesday at a conference we had organized a new emerging pandemic threats program using FY 2009 monies, which we plan to have fully launched by October of this year. This program, which we will initiate in strong collaboration with our colleagues from the Centers for Disease Control and Prevention, as well as our colleagues from the U.S. Department of Agriculture, is intended to support the development of a global early warning system for the threat posed by diseases of animal origin that infect humans. The objective of this new program is, in fact, to preempt or combat at their source the emergence of new diseases of animals, such as H5N1, H1N1, or even the earlier SARS or HIV, that pose significant threats to public health. I need to be very clear that this effort builds on the agency's ongoing work for H5N1. Clearly, the platforms which have been supported by this Congress to respond to H5N1 has given us new capabilities and understandings to address these threats and mobilize a global response that should allow us to better predict and respond, and in effect put the canary back in the mine shaft. In closing, let me say that even as we do not yet know how severe the novel H1N1 pandemic will be or how long it will last, as the lead U.S. agency for foreign disaster assistance, we will continue to provide emergency support to countries in response to this threat. However, even in the face of the immediate threat posed by H1N1, recent history has been very clear on a core lesson. We must remain vigilant in our response to the larger threat posed by emerging pandemic diseases if we are to be able to ensure a secure future for the world's population. Thank you very much.
Let me thank all of the panelists for your very incisive testimony. I will yield to the gentlelady from Texas who says she has to leave to conduct a hearing herself, and because of the death of Texan, she wants to, I will yield to let her ask a question before she leaves.
Thank you, Mr. Chairman. I'll, in essence, put these two questions on the record and probably will not be able to be here for the response, but I'd greatly appreciate the response because I believe Texas has been the epicenter, particularly for its proximity to Mexico and the increasing number of cases that we seem to be determining. One, what will be the reimbursement procedures for health facilities, clinics, and city and county health entities that have been in the midst of this? And I convened a meeting of these individuals last Friday, and they do have a long litany. Two, will you continue to provide the I believe it's the Laboratory Resource Network one-day testing confirmation, which is urgent? And three, will you, as we move into the graduation season, our school districts in Texas, universities are in a flux about whether or not these large venues will be allowed to continue. And I would very much thank you for the answers to those questions. Mr. Chairman, thank you very much, and I yield back.
Thank you. We will now hear from the ranking member, Mr. Smith, and then we'll hear from Representative Woolsey, who also indicated she has to leave.
If she has to go first, that's fine.
If you have to leave, if you want to go first, Mr. Smith said that he will yield to you.
I don't have to go right yet. I have about 5 minutes.
All right, then I'll yield to the ranking member.
Thank you. Again, I want to thank our very distinguished witnesses for the great work you're doing, but also the insights you provided to the committee today. First, Dr. Carroll, the USAID reported that the Humanitarian Pandemic Preparedness Initiative convened a 3-day conference or exercise to improve the capacity to avert and respond to the pandemic in East Africa. You indicated that some other similar type of exercises are likely to occur. What kind of deficiencies are we gleaning from that exercise as they exist among some of these countries? You talked about some 800 personal protective equipment kits being deployed, and I would suspect that's for the healthcare workers especially, so that they can go out and do their work without contracting the disease. But what was learned in terms of any gaps that need to be fixed from those exercises?
Congressman Smith, thank you very much for this question. And in fact, it's an important one because from a humanitarian response perspective, having the opportunity to prepare for a disaster in advance is a rare opportunity. For tsunamis or earthquakes, we are usually in a reactive mode. And one of the critical challenges and frequently one of the critical failures of an emergency disaster response is poor coordination. One of my colleagues who specializes in emergency response has frequently commented that when they write on the death certificate the cause of death, more often than not, it should not be malaria or diarrhea. It should be poor coordination. I say that point because the exercises in Addis Ababa and shortly in Johannesburg and then in Ho Chi Minh City are intended to bring national authorities together across civilian, non-governmental, and military representatives to arc out and clearly identify roles and responsibilities, to establish in advance coordination principles, and to ensure that the lines of authority and the lines of appropriate action are there, understood, and that they have an opportunity in these meetings, such as we just hosted in Addis Ababa, to go through a simulation exercise that allows them to test their plans, identify their weaknesses, and then to be able to further improve and refine. The other advantage of these meetings, these regional gatherings, is that there is also significant issues having to do with cross-border movement of populations. And these fora also offer that opportunity for national authorities to interact with each other and to identify what might be some of the critical issues, which certainly have arisen in our own situation between the United States and Mexico. So those are the key issues. I can say Addis Ababa was certainly benefited by the timing from H1N1, and we look forward to certainly the activities rolling out in Johannesburg and Ho Chi Minh City. And as I mentioned, we have a similar exercise in Rome with respect to the mill-to-mill activities as well.
Just one quick follow-up. I have more for the second round, but if there's is any special attention being paid to those countries where the system really is broken, particularly in a dictatorship, particularly in a place like Sudan, which could quickly find all of its current problems exacerbated and exponentially compounded, I should say, by a pandemic breaking out. It seems to me that the vulnerable become even more vulnerable. And what provision, we're talking about stockpiling, Tamiflu, and other kinds of interventions to help alleviate those who contract it. The developing world and the poor, will they have access to those as well?
Well, let me say two things. Part of the issue that you talked about was the ability to deliver delivery services. That's one of the reasons we've gone into a partnership, for instance, with the International Federation of Red Cross and Red Crescents. They frequently act as a parastatal responsible for humanitarian response. And clearly, when you think about Sudan, they have a critical role to play in countries where governance is clearly an issue. In terms of the services that are looking to be provided, we are right now going through our fiscal year 2009 budget, and in particular looking at our avian and pandemic influenza resources to see to what extent we might be able to free up resources with an eye towards being able to make immediate contributions to the kind of expanded commodity support beyond that related to pandemic, to the protective equipment that we already have. And so we are working closely with our colleagues at Centers for Disease Control to identify what those resource needs might be and then look at how we might best be able to address both pharmaceutical and non-pharmaceutical as well as delivery competencies. Okay?
Thank you very much. Representative Woolsey.
Thank you, Mr. Chairman. Somebody has to help me with this, and I think you can, because I don't think I'm the only one that's looking for the big picture and questioning how when we have for the seasonal flu 3 million to 5 million people getting the flu every year, and internationally 250,000 to 5,000 people dying. In the United States, the average is 36,000 deaths from seasonal flu, and so far this year, 13,000 deaths. Okay, where along this H1N1 line, where do we get to the point, and what are you looking for until this becomes ho-hum seasonal flu? I mean, because it just seems out of context and out of, go ahead, Dr. Schuchat.
Yeah. You know, seasonal influenza does have a large toll on health in the United States, despite the fact that we vaccinate many people for it and that many people are immune already because of exposure to similar viruses. The difference with a new influenza virus like what we see right now is that we don't expect very many people in the general population to already be protected. So it means everybody's vulnerable. Your question of whether this particular new virus is going to look like seasonal influenza in terms of that 36,000 deaths in the U.S., will it look worse than that, substantially worse than that, or not that bad? We unfortunately don't know. We know that this influenza virus can cause severe disease, just like the seasonal strains can. And we know that it's easily transmissible, as we've seen in the New York City school outbreak and so forth. But we don't know whether over the weeks ahead it will just fizzle out and not come back in our fall season, or whether it will mutate and become a bit more severe, or whether it will have the similar amount of severity as it has right now. If it keeps this similar severity, we are concerned that among the people who are sick and who are becoming hospitalized are younger persons who don't usually get hospitalized with flu, seasonal flu. So unfortunately, we don't have that crystal ball, and with influenza, a new strain in particular, our predictions really need to be cautious.
Just to add to that, Congressman Woolsey, as we've said all along, influenza viruses are inherently unpredictable anyway. When you have a virus that you've never had experience with before, that compounds the unpredictability. So I don't think any of us are going to feel that this will become oh-hum, as you said, because we have to continue watch what it's doing and then what happens in the fall and in the winter. So there's a lot of things that we still are uncertain about, as Dr. Schuchat said. So I don't think this will become a oh-hum thing. Even if it remains relatively mild and acts like a seasonal flu, we're going to be watching this very carefully.
Thank you. And Mr. Chairman, just a remark, because I do have to leave. I was in Tanzania over the Easter break. The women giving birth have to bring their own gloves to the clinics and their own supplies. How are you going to distribute these kits? I just can't see how that can happen.
Thank you, Congresswoman. Obviously, it's a challenge. There's no question about that. Africa has been a remarkable challenge in terms of meeting the infrastructure needs and the human resource issues plaguing the health systems there are enormous. Quality control issues are a major challenge. Let me say we've drafted an initial plan about service delivery, part of it having to do with infection control within health facilities within the very settings that you're talking about. So part of this review we're going through right now is to really focus in on those countries where we feel the vulnerabilities are greatest and what lines of actions we can take. Infection control, as you are describing right now, is clearly a major issue. And so we will be working with our international and U.S. colleagues to assess how we can most effectively do this in an environment, as you know, is very, very challenging.
Thank you, Mr. Chairman.
Thank you. Congresswoman Lee.
Thank you very much, Mr. Chairman, and good morning. I want to thank all of our witnesses for being here and presenting your very clear and succinct testimony. Let me ask you, going back to the continent of Africa, noting that there have been no reported H1N1 diagnoses. Surveillance, we know, is an issue on the continent. What healthcare systems, in terms of labs, in terms of healthcare workers, is an issue. Infrastructure. What do you think is going on the continent? I mean, do we believe? Can we anticipate cases, or do we believe that for whatever reason there just are no cases on the continent of Africa? And also, what should we be doing? And I was just reading the President's statement, which I think is a great statement, and I want to also commend him for his leadership, because we all recognize that not only is this a public health emergency and a humanitarian crisis, but also a national security issue that we have to recognize as such, and this is the way to address it within a comprehensive fashion. So what, in terms of the continent of Africa, what do you think are some of the key investments that we need to make to really begin to address this in a big way in terms of the spread of this disease and other diseases? And also, what do you think the real reason is that we don't see any signs yet on the continent? And none of the countries, as I look at this chart, have any cases at all.
I can start with the issue of what's going on in Africa. One of the values of the investments that have been made in global health is the international network that we have. CDC has people in over 45 countries working on a variety of issues, things like PEPFAR, polio eradication, measles, and our global disease detection program. And we've been holding very frequent phone calls with all of our international staff to both share information of what's going on here and learn from them situational awareness of what is happening. Also, they have facilitated our providing these diagnostic kits for the new virus so that laboratories in some of these countries will be able to test right there without shipping to one of the WHO labs or here to the U.S. to CDC. We don't yet have confirmed cases from Africa, but I share your suspicion that that doesn't mean they haven't happened yet. There are lots of variables in terms of temperature and populations and travel. And so where the disease has been confirmed, so far it's been related initially to travel exposure to Mexico. At this point, with disease in the U.S. and Europe and New Zealand and many other places, the risk for Africa continues. So one of the issues is how do we find out what's going on, and I think that's through our investments in laboratory capacity, epidemiologic capacity, training so that the next generation in these countries will be able to detect and respond, communication and information technology so that we can know what's going on and share that information, and really the governance that allows the different networks to interact. We're working not just with the CDC network, with the WHO network, with Pasteur Institute, of course with the AID missions. So I think that, and then the other comment is that some of Africa is in the southern hemisphere where we would expect a reverse season from what we are seeing. In particular, we have strong collaborations in South Africa, which does have very good laboratory capacities, and that's a place we're going to be looking intensively to understand whether this virus emerges in the summer.
And if I add to the answer, I think it's reasonable to assume that this virus will show up in the subcontinent of Africa. The problem of detecting it will be significant. There are steps there. Your question really had a two-part component to a temporal component. What can we do now to ensure that we can pick up this virus at the earliest possible moment for the purposes of being able to track it, monitor it, and deliver life-saving interventions as needed? But the second part of your question had to do with seeing this as symptomatic of a broader array of challenges within Africa in terms of picking up new diseases and being able to respond. Specifically, I can say two things about that from USAID's side and, again, with our partnership with Centers for Disease Control. We are looking to have a consultation with CDC next week that we will hopefully will include WHO and FAO that will identify immediate actions that we can take, and part of this reprogramming of some of our resources will be specifically asking how can we make investments immediately with resources on hand to increase the likelihood of picking up this virus. So create a better, more focused and coordinated effort towards that end. Second part of the question has to do with the broader issue of being able to pick up diseases before they become large public health threats within the region. I mentioned to you that we have launched an emerging pandemic threats program. This is a 5-year down payment program that has as a central part of it investing in a network of laboratories within Africa specifically intended to increase our ability to diagnose both within animal and human populations new emergent pathogens that will be in a better position to signal when something novel is occurring and help us to more effectively respond. So that is part of a systems approach towards responding to the larger, more long-term challenges. So two-part, immediate consultations, reprogramming funds, and creating an opportunity to diagnose now and take simultaneous steps for the longer term.
At this time, we'll hear from Ambassador Watson.
Thank you, Mr. Chairman. And one thing I would ask of the witnesses, can you get to the media and ask them to stop identifying this as swine flu? I think that educating the general public about this new strain is very, very important. And as I monitor the media, both written, television, and radio, they're referring to it, and that gets people in an uproar. It is not swine flu. And so if you could help us with that, I'd appreciate it. Let me direct this to Dr. Fauci. I understand there are 2 vaccines already, Tamiflu and Influenza, that are on the market that are sensitive to H1N1. But how close are we, and all of you can jump in, to finding a particular vaccine that would be specific to H1N1?
Thank you for the question, Congressman Watson. Tamiflu and Influenza are treatments. They're used to treat people who get infected and to mitigate the severity of disease, and sometimes used in prophylaxis to prevent. Your question about vaccine is one in which we are already started the process on the multi-step process towards developing a vaccine. And as this, I don't think you heard it in my opening statement, but very briefly, what happens when you get into a situation like this is you isolate and characterize the virus. The CDC has already done that. They are currently in the process of developing what we call reference strain or seed viruses. Seed viruses are grown up for the purpose of then collaborating with our pharmaceutical company partners to give it to them so that they could start growing it up in large amounts for 2 reasons, sometimes in parallel. It's to develop what we call pilot lots of a vaccine. We are not there yet because we're still at the process of the seed virus growing up to be able to give to them. Pilot lots are then put into what we call clinical trials by the company themselves, or more often than not, by the NIH's clinical trial network, to determine three things. Is it safe? Does it induce the kind of immune response that would be predictive of being protective? And what is the right dosage and number of doses? At that point, then you have the option, this decision for that has not yet been made, of scaling up in manufacturing level, what we call manufacturing scale-up of tens of millions of doses, to then make a decision at another critical point in that process what you're going to do with it. Are you going to administer it? What are you going to do? So right now, the very earliest of the stages of that stepwise process has already begun.
Thank you for that information. I'm a bit confused as to who is most susceptible. Is this H1N1 flu or strain of flu running across age levels? Are young people, middle age, older people? I've heard several different things over the media. Dr. Schuchat.
Sure. Of the cases that we have confirmed here in the United States, they are primarily in the age groups of 5 to 50. This is different from the usual influenza season where we see a lot of disease in seniors as well. We don't know yet whether this disease will become quite common among older persons or whether people over 50 may have some protection against this virus, perhaps because of viruses they saw when they were young, or perhaps because of other factors. But it's also possible that in the U.S. the virus first emerged in teenagers and young adults, and their social networks are such that they're spreading to each other before we eventually see disease in older age groups. So right now, we don't see the pattern of lots of hospitalizations in very older people and very young people. Even the hospitalizations that we have primarily are in that group of 5 to 50. So it's confusing because the seasonal flu doesn't look that way in terms of the risk groups we talk about. I would say, though, that we do have some information already that people with underlying medical problems might be at higher risk in terms of our hospitalization data. It's very preliminary, but as we review those data, we do note that some of the people who are requiring hospitalization have underlying medical problems that would be classical risk factors for influenza. So unfortunately, I gave a really long answer. Unfortunately, it's early and things may change, but right now we have a little bit of difference with the seasonal flu and a little bit of similarity with the underlying diseases.
And finally, some of the schools, I'm out in Virginia, are opening back up. Parents are very confused, and they want to be able to plan their lives, and I know that's kind of improbable at this particular time. But some of the smaller schools, the private schools, are staying closed. What does that indicate?
You know, this is a challenging time for families and communities because information is changing quickly, and of course, when our children are involved, that hits right to the heart. The CDC has been working with the state and local public health officials on the response. We issued guidance always saying that local and state decisions really are important because the circumstances in the community, the locals have so much more information than we do. Yesterday, we announced updated guidance that the schools that were closed could reopen and that people could really focus on making sure sick children stay home and that the teachers and parents are attuned to whether children are ill, and we try to keep the ill children out, but let the other children benefit from school and school lunches and so forth. So I think it's a challenging time, and each of those school authorities are making decisions, hopefully in conjunction with the local public health officials. There are other circumstances, like whether the teachers left town and are back and able to reopen. So I do think the next several days there'll be variability, and we really want to make sure as we find new information, we get it out and people can react appropriately.
Thank you. Thank you, Mr. Chairman.
Thank you. Dr. Schuchat, you mentioned in your testimony that CDC funds over 30 countries in pandemic preparedness to improve their ability to detect and respond to pandemic flu. Would you be able to tell us generally what countries these are that you're funding?
Yes, we actually, I believe for influenza, we either directly or indirectly support more than 50 countries. Some of that is through a person assigned to work in the country, either with the World Health Organization or the Ministry of Health. Some of that is through cooperative agreements where we provide funding for the countries, and some of it is through networks that we're part of. We can provide the committee a list of the countries. There are originally we had some priority countries related to where the H5N1 virus, the avian flu virus, was emerging primarily in Asia and some in Africa. We actually have expanded to make sure that we have support really to all of the developing country regions, often through the World Health Organization regional offices, sometimes through PAHO. So even though our eyes were really keenly pointed towards Asia, we have been working with Latin America on the pandemic preparedness. But we'll be able to offer you a list of the individual countries. We do have a number of countries in Africa, and we have 11 countries in the Southern Hemisphere that have gotten support from us.
Mm-hmm. In Europe, what organization do you work with? Is it through the EU or individual countries? What is their sort of CDC, NIH component? Is it the European Parliament? Is it...
Yeah, there are a number of organizations, and of course that's one of the important aspects of this is coordinating across the governments. We work with the World Health Organization, working in all regions. We also work with the European CDC. Our CDC in Atlanta has seconded an influenza expert to the European CDC in Stockholm, and we've been working very closely with our colleague there over the situation in Europe. We also have liaisons assigned to the FAO and the OIE related to all of this human-animal interface work and understanding what's going on in animal populations around the world, as well as in the wildlife. So I think that we're trying to stay connected. A lot of the leadership globally comes from the World Health Organization in Geneva with the Director General, Margaret Chan.
Thank you. I hear you mention some of the military AFRICOM and so forth. Is there any component in NATO, since that tends to be a quasi-political, although military organization? Have you worked with them in this area?
Thank you, Chairman. We have not worked with NATO. The reason we're working with AFRICOM and PACOM is that we did essentially a risk analysis. Were there a pandemic virus similar to the one that emerged in 1918? And I can say we did this with the Central Intelligence Agency. We basically identified how that might play itself out around the world in terms of mortality and morbidity using a variety of modeling factors. Those countries largely fall within the Africa and the Asia region. Our focus is clearly going after where the risk is greatest, the burden is maximum. So where we entered into the agreements with PACOM and AFRICOM is with a focus towards those countries in that regions where the vulnerability is greatest. As with respect to NATO, that is not something we have direct engagement with. Thank you.
Now, with the H5N1, that's what everyone was expecting to come back. And in Egypt, where I think there was some real problem with that, it seems that they went and killed 350,000 pigs. Do you think it's a overreaction, or do you, is it tied into their fear of the H5N1 and whether there could be a connection between H1N1 and H5N1?
Again, thank you, Mr. Chairman. Let me first off say, in terms of the government of Egypt, we have a very strong and very good program with them, specifically with respect to H5N1. And they have shown extraordinary leadership and effectiveness in their program over the last couple of years. The events over the last week where swine throughout Egypt have been targeted, quite frankly, is an unfortunate one. There's been no documentation of H1N1. It clearly is an overreaction at this point, and there's no apparent public health value. We have been in direct consultation with the government of Egypt with respect to this issue, and we will continue to do so. But our focus remains strengthening their H5N1. And even as we talk about H1N1, this is an issue of H5N1 that we need not lose focus on. It remains a very dangerous virus. Mortality rates continue to be in excess of 60%. And if I may just add, H5N1 has been one of those success stories over the last couple of years. Were we sitting here 3 years ago in 2006, we would be talking about 53 countries with reported confirmed outbreaks of H5N1. We've just finished what is, in effect, the H5N1 transmission influenza season, end of April. This past 2008-2009 influenza season, that number has gone from 53 down to 9 countries. And of those 9 countries, 4 countries account for 95% of all outbreaks involving animals or humans. So there's been a tremendous progress in terms of moving this virus back. And the platforms that have been invested in for surveillance, for coordinated response, for communications, for laboratory strengthening, those are the very platforms we're looking now to adapt in other parts of the world where the H5N1 is less of a risk now to this broader agenda of dealing with other emergent disease threats. So the support you have provided, quite frankly, has been hugely successful, led to a huge success with this respect. And the U.S. government across the board has played a disproportionate leadership role in delivering support for this global effort. But back to Egypt, it continues to be a point of concern.
Thank you. My last question, I'll yield back to the ranking member. Just Dr. Fauci, I'm just curious. The 1918 flu was just came out and 50 million deaths. Nothing like it before, nothing like it after. What is there the potential for another Spanish flu type, or what was so peculiar about 1918? Do you know? It was just unbelievable to have causing more deaths than the war going on. Could you have any?
Well, the answer to that is it gets back to what we had been saying just a little bit ago about the unpredictability of pandemics, the unpredictability of influenza, particularly when you have a brand new virus to which the community has never been exposed. That was the scenario in 1918 when you had the first H1N1. And as you know, historically, it came in the spring and was acting in a way that was not substantially different than what you'd expect from a flu. But then it turned around in the following fall and winter, came back with, as we say, with a vengeance, and was very devastating. We don't know the reason for that. We've studied from a molecular virological standpoint some of the signatures of what might be related to virulence or not, or spread. But it still remains a mystery how and why that happened, which is always the case with potential pandemics, which is one of the reasons why we're so vigilant now and we take this seriously and continue to take this seriously. We don't want to get anyone alarmed that this is a 1918 type at all, and I don't think we should even be talking about that. But the fact is, when you're dealing with brand new viruses, influenza viruses, to which the population does not have any experience with, no background immunity, you have to have an overabundance of diligence and caution, which is what you're seeing right now and how we're responding here.
And just the last point on that, how was the breakdown of the 50 million here in the U.S. and Europe?
There were 500,000 people in the United States who died. the 50 million, 40 to 50 million were distributed throughout the rest of the world. But in the United States, there was at least 500,000 people who died in the 1918 pandemic.
Okay. Thank you. And we won't talk about it anymore. Like you said, we'll try to go forward. Thank you. Mr. Smith.
Mr. Chairman, thank you very much. Dr. Schuchat, if you could, with regards to the Global Disease Detection Program, the GDD centers in Kenya, Guatemala, Thailand, Kazakhstan, Egypt, and China, do they operate in a regional mode? And are there any countries that are outside of their reign of influence?
Yes, the intent of the Global Disease Detection Centers is to both work with the country through the Ministry of Health and also to provide regional leadership for training for laboratory and epidemiologic capacity development. At this point, there are 6 full GDD centers. There's a few other sites that are carrying out some of the components, but we don't really have the entire globe covered. We are making sure that where we do have these integrated centers, they're able to provide services way beyond the national borders, but there are some gaps probably around the world.
For the record, could you provide what countries to date have not been included in that regional coverage? It seems to me an opportunistic infection, if all of a sudden something breaks out and it goes less than it could have been detected had we had that kind of surveillance. If you could provide that for the record, I'd appreciate that. With regards to our operations in China, what protections, and this would be for all of the countries, of course, but I've spent an enormous amount of time working human rights issues vis-a-vis China and have grown increasingly alarmed about I even had a hearing in this room on the transplantation of organs, which is done routinely in China through the death of the prison or the inmate population. And there's great concern that Falun Gong, political prisoners, other religious prisoners become fodder for experimentation. And I'm wondering, with regards to China, in our interface with them, what protections, what kind of best practices, ethical and otherwise, do we insist upon, and this would go for any of our distinguished witnesses, so that human subjects are protected and the most vulnerable, someone who is a prisoner, is not compelled into signing a disclosure or a informed consent when he or she have no ability to resist, and then they become the subject of an experimentation. How do we protect human subjects too?
The CDC has quite a number of collaborations in China, including our Global Disease Detection and Response program there. And when we are involved in activities, the international standards for human subjects research are always followed. The NIH also probably wants to comment on this, but this is a U.S. government-wide requirement. We're not allowed to provide funding to entities that don't follow the appropriate institutional review board.
But are we able to exercise the kind of oversight? We know that when it came to drugs, there were some serious problems with drugs that were manufactured in China. Even baby toys and children's toys were laden with lead, which raised serious problems about quality control. But the record on human rights in China is an abysmal record. It is beyond poor. It is among the worst in the world. And it would seem to me that if we're not checking that ethical standards are being consistently and aggressively applied, human subjects, especially if we get to the point of another Spanish flu-like situation where panic sets in and we've got to find an answer to this, becomes the modus operandi, human subjects could very quickly become utilized in experimentation.
Yeah, the ethics of what we do is vital, and I think I would say that the exchange and collaborations that we have with China are a very positive step in terms of ability to influence each other and work in a transparent way. We've probably advanced this quite a bit in the past several years.
Could you, as a result of this question, maybe look into it even further? And I raise that again. Again, we had a guard testify here who Harry Wu smuggled out of the country, who told how they would not kill the prisoner, but then they would kill them, he or she, through a capital punishment regimen, only after they took the desired body parts, mostly internal organs. And we had an enormous amount of collaboration for that. And I would hate for us to be less than vigilant in ensuring that no human subjects are abused, particularly the prison population, political prisoners especially. And Dr. Fauci, did you want to? Okay. With regards to Russia, are they involved with the GDD Center? I mean, how do we interface with Russia, which could be experiencing this?
One of our centers is in Kazakhstan, so that's the regional place. Some of the places we've established centers have been ones where enhancing capacity would be very valuable, and other times it's been a place of strategic importance. So our work in Russia is not necessarily through our Kazakhstan center, but more bilaterally at this point.
Okay, just briefly because we're running out of time. Dr. Fauci, you mentioned that the H1N1 virus is sensitive to Tamiflu and Influenza, but experience tells us that resistance to influenza antiviral medications frequently emerges. What other potential treatments are in development? And finally, Dr. Carroll, refugee populations, the 25 plus million who are of interest to the UNHCR High Representative, any special concerns being expressed by the UNHCR, working with WHO, with us, to ensure that we don't get a massive outbreak in the close confines of a refugee camp or something like it?
Well, let me answer the first question about resistance. That's one of the reasons why we have a very active and aggressive program of drug screening and drug development. There are already a number of compounds that are in the pipeline, some of which are being tested, some of which are in preclinical development, to try and, as we say, keep a pipeline of drugs available in the eventuality that we might see resistance. And we've seen that on and off to various anti-influenza drugs through the regular pandemic flu season. Fortunately, we've not been in a situation where there's been resistance to all of them. There have been resistance to one or the other. But the precise answer to your question is that is the precise reason why we have a very active drug development and screening program.
Congressman Smith, thank you very much. The question about the vulnerability of refugee and migratory populations is clearly a major one. And I mentioned in my comments that part of our strategy for pandemic preparedness was to enter into an alliance with the family of the United Nations. It includes, in fact, UNHCR and IOM. We, in addition to the 30 countries that we're working with to develop pandemic preparedness plans and test those out, we've been working explicitly with UNHCR and IOM to make sure that the large populations of refugees that fall within the world have adequate planning, capability, and identification of needs. And so we've been working very aggressively with them, and it's a major part of our effort, and they're a major recipient of support from us. And I might just add that today in Paris, yesterday and today in Paris, all of our UN and international partners are, in fact, including UNHCR and IOM, are explicitly addressing the issues of populations of refugee populations and migratory populations. All right? Thank you.
Thank you very much. Representative Lee.
Thank you, Mr. Chairman. Dr. Schuchat, at the end of your testimony, let me just read you one paragraph. You said, the government cannot solve this alone, and as I have noted, all of us must take constructive steps. If you are sick, stay home. If your children are sick, keep them home from school. Wash your hands. Take all of those reasonable measures that will help us mitigate how many people actually get sick in our country. I read this and I said, okay, is this a teaching moment? And I say that because these are standards that we should follow each and every day in terms of public health, in terms of prevention, in terms of making sure that the transmission of infections and diseases are reduced. And so one is this a teaching moment? Can we mount a public information campaign so that people understand how to prevent the transmission of other types of infections and diseases? And also, secondly, is there anything else we need to do as it relates to H1N1?
Yeah, thank you for that comment. the advice about hand washing and these sort of basic guidances are prudent for this particular virus, but as you say, they're also helpful for other respiratory infectious diseases. And we're very pleased that the Harvard poll results came out a few days ago and said that 59% of Americans say that they're washing their hands more than they ever did in the past. I think it's going to be important to sustain that type of behavior, not just when you're fearful because you're bombarded on TV, but over the long haul because it can really help a lot of infectious disease transmission. You know, I think there's another thing that we can do long term. It's really important for people to know that seasonal influenza is an important public health problem. We hope this new H1N1 strain will not become more severe and cause lots of problems. And of course, we're working aggressively to attend to what needs to be done in the short term. But year in and year out, 36,000 people die from seasonal influenza in the U.S., and we do have a better vaccine manufacturing capacity than ever, and we really want people to know they can protect themselves from that infectious disease year in and year out. A lot of steps in play for vaccine development work against this new strain, but that's the kind of long-term guidance that we think is important.
But with this new strain, are there any additional precautionary measures that people should take?
Yeah. You know, the other thing that is important is to plan ahead. You know, the behavioral advice we've made about washing hands and stuff will help with reducing respiratory infections. But if we do see a substantial increase in illness, hospitalizations, and social disruption, we think people need to be prepared for how they're going to manage that kind of disruption in the family or the workplace. You know, we're also reminded we're coming into hurricane season, tornado season, these types of things, and knowing, you know, how to handle the types of disruptions with your family, the family communication plan, the provisions that you have, the way you're going to stay in touch with people. Those are important steps, whatever the disaster or emergency is.
Thank you very much. Could I ask one more question of Dr. Fauci? Dr. Fauci, good to see you again. Of course, concerns many of us have regarding the impact of H1N1 now and in the future on underserved communities, particularly communities of color, the uninsured here in our own country, and of course outside of the country. So what steps are we taking to ensure that individuals who are not insured, who are educated properly with regard to prevention, but also have access to the preventive types of measures and the type of treatments, if in fact they're uninsured, no insurance, end up in the emergency rooms, you know what I'm talking about. So, you know, we have an additional problem here in our own country with 47 million uninsured.
Yeah. Well, I'm always happy to answer your questions. That's not an area at the NIH that we're involved in, but I can tell you that one of the things that has been done, and I think very well by the CDC, is to get the message out broadly to everyone that you possibly can get to. We always are faced with a system of healthcare issues in this country, and people who are underserved in any disease, generally, particularly people in poverty, tend to do more poorly than others, and we've seen that with virtually every disease that I've ever testified before this committee for and other committees, and that's just something that hopefully will improve as we get the healthcare delivery system better.
Okay, thank you very much, Mr. Chairman, because I think as we look at H1N1 and all these other diseases within the context of developing a universal healthcare system, we have to look at how we rev up in communities that are left behind. Thank you.
Representative Watson.
Yes. At the end of this month, Codell is going down to South Africa to take a project to our library in Soweto, an information center. Possibly, if we have a CDC location down in that area, we might take some time. We're going to fly into Johannesburg, and we are going to look at a PEPFAR program relative to AIDS. Since there seems to be no reported cases on the continent, we might want to go to a CDC center and get an update. Do we have a CDC center in that area?
CDC has a large program in South Africa based in Pretoria, and
we are going to Pretoria.
Yeah, most of the activities are PEPFAR TB related, but there actually is influenza work going on as part of the CDC cooperation with South Africa. And if you're in Johannesburg, you'd be able to see it right there.
Very good. Thank you.
Thank you. Overall, let me just say, would you say that CDC's work is focusing on building capacity of health systems, particularly in Africa and Latin America? Is that one of your goals?
You know, we certainly think that improving capacity is vital to the long-term protection of populations, you know, in Africa as well as in the U.S. And so the strategies that we have for our investments and collaborations in Africa are not just one-time interventions, but really with a mind towards sustainability. Part of our PEPFAR strategy is to work directly with the ministries of health and really improve their ability to long-term strengthen the health services, the evaluations, the ability to improve policies and such. So I think that it's a huge mission, but we do try to do our technical support in a way that will be capacity building.
Thank you very much. How about USAID's work in this area, also focusing on capacity building in particular, but not just to combat pandemic influenza, but overall to combat HIV/AIDS, tuberculosis, malaria, neglected tropical diseases, and things of that nature? How does USAID work in this area?
Thank you, Chairman. First off, I think it's worth noting that the efforts in these countries are all part of a very well-coordinated U.S. government response. So as we speak about what USAID is doing, I think we also are reflecting what CDC and other colleagues are doing as well. And PEPFAR, the President's Malaria Initiative, the TB programs that we are all supporting clearly have at their center the investments in local capacities. These are insidious diseases. They are only going to be solved if solved and for the long term if there are the local capacities at national, provincial, district, local levels to be able to carry out these activities. So there's a major investment, and I think it was reflected yesterday in President Obama's announcement, the whole issue of health systems. That has been a major area of challenge over the last decade as we've rolled out other programs, and understanding and investing in what the system capacities to deal with HIV/AIDS, to deal with malaria. That is a centerpiece for our work, for Centers for Disease Control's work as part of these larger programs. So I think the answer to your question is yes, capacity building and indigenous strengthening is at the heart of our program, but I think at the U.S. government's program at large. Thank you.
Thank you. Dr. Schuchat, your testimony, you mentioned the CDC's Global Disease Detection Program, the GDD centers in Kenya and Thailand and Kazakhstan and Egypt and China, and Mr. Smith mentioned it also. Do each of these centers have the capacity to detect this H1N1 strain? And what other diseases, if they do, can they detect at the centers, such as MDR and XDR TB? And what are we doing to build lab capacity in general? As we dealt with MDR and XDR TB, once again, as you mentioned earlier in your testimony, that South Africa had the capacity to have labs. We found out that there were 20 labs in all of sub-Saharan Africa that could detect MDR, XDR TB. 19 of the 20 were in South Africa, one in the rest of the other 52 sub-Saharan African countries. So there's definitely a disparity and a very lack of the ability to really detect. And so when we were trying to determine how severe, we knew the damage that MDR and XDR was doing in South Africa. Archbishop Desmond Tutu sent a letter to me about 2 years ago where he mentioned that at a hospital in Cape Town, there were 53 patients that were HIV positive, and the MDR strain of tuberculosis was detected in that particular ward. Out of the 53 patients, 52 died within 2 weeks from the either MDR or XDR TB, and that's when he sent me a letter, and we started we got a $50 million additional appropriation out of overnight, really, and then a large amount, I think $400 or $500 million to deal with MDR and XDR. But how do we stand in that area?
You know, one of the strategies for the Global Disease Detection and Response Centers is to strengthen laboratory capacity for the known, but it's also to strengthen the ability to detect the new or unknown. So yes, we have had respiratory infectious syndromes as a priority for the GDD centers, and they've been trained to recognize the typical and then the unusual respiratory infections, including unusual influenza strains. And of course, we've recently shipped out these new kits for the novel H1N1 strain. But the centers also work in an integrated way, the laboratory strengthening with epidemiologic and rapid response teams to really respond when there's an unusual cluster and we don't actually know what it is, so that their investigation will permit us to find the new. You know, one of these sites in Thailand was very helpful in the SARS epidemic in assisting in other countries in that region in understanding what that new particular virus was. So with infectious diseases, you know, certainly something like MDR-TB is a major concern and priority, but we also need to be ready for the new and unpredictable and have high-quality, trained laboratory staff who can adapt some of the molecular techniques for one infection and look at others and really know how to work in partnership with reference support. So I would say that there's lots more readiness that we could have for a long list of important infectious diseases, but it's also a strategy of ability to respond to something new and potentially concerning.
Thank you very much.
Chairman.
Mr. Smith?
Thank you, Mr. Chairman. Just one final question. It was reported that the woman who died this morning, apparently attributed to H1N1 influenza, she was pregnant, she had a cesarean section, and her baby was born apparently healthy. Every year, about 4 million babies are born in the United States. If this comes back, especially more virulent and, you know, our worst nightmare, what thoughts are being given, what precautions are being taken, what special protocols perhaps are being devised to ensure that pregnant women who may need a different kind of case management if they get sick are protected as well as their unborn child? I mean, we're talking about two patients, mother and baby. I'm not sure, you could tell us, our committee, you know, is this like HIV/AIDS where HIV contagion can be transferred during the birthing process? And we know that certain drugs can mitigate that, which are now mother-to-child transmission has been cut significantly. But so I don't know that answer, and I really would like to know. This baby was born via C-section, but 4 million kids and their mothers could be at risk if this comes back, and depending how long it does last.
You know, we know from seasonal influenza and studies in the past that pregnant women are at higher risk for complications of regular influenza, and they're one of the groups that we've always recommended get influenza vaccine each year to help protect them and their babies. The preliminary information that we have right now on the cases in the United States doesn't, as of today, suggest that pregnant women are at greater risk than the general population, but it's an important issue that we're monitoring. We've also issued interim guidance for care of pregnant women, you know, the ways to diagnose and to treat pregnant women, because as you know, many medicines are not necessarily tested as fully in that population, and yet physicians and their patients need guidance. The third comment is that the antiviral drug oseltamivir had not been licensed for use in young children under 1, and one of the things that happened in the past 10 days was an emergency use authorization was approved through the FDA and CDC and HHS, so that use of that drug for younger ages, not for newborns, but for older babies, would be available under certain circumstances. So I think the vulnerable infants, newborns, the pregnant women are always a concern, and influenza is a particular challenge in those populations, but we're trying to stay focused on it.
Does the virus go through the umbilical cord, or is it stopped? If the mother has it, does the baby get it?
Yeah, I'm not familiar with that as a route of infection, but with a new virus, we always are mindful that there are lots of things to learn, and so this particular H1N1 influenza virus, I'm not aware that we have any mother-to-baby transmission, but with viruses that can happen for many of them. So,
but we're looking for that to see if that's a possibility.
We are looking actively at all routes of transmission right now.
Okay. Thank you.
Well, let me certainly thank each of you for your very important testimony. It's something that we are proud that we're able to be prepared. As you've indicated there, years ago we would not have all of these various procedures in place, and so I really commend the work that CDC and NIH and all of you that work in government agencies, USAID, are doing. I also once again commend President Obama for the $63 billion that will certainly over the next 6 years it will really continue our vigilance in working to try to eliminate HIV and AIDS, and tuberculosis, malaria is really getting a tremendous amount of attention, and we're seeing very good results in other, tropical diseases that have not gotten the attention, river blindness and other kinds of tropical diseases. So we're very, very pleased. Congresswoman Jackson Lee has additional questions, which we will forward to our witnesses, and we'll ask that you respond to these in a timely manner so that we can get the answers back to her. And we certainly greatly appreciate your participation. Before closing, I want to ask for unanimous consent for members to have 5 days to revise and extend their remarks and submit questions for the record without objection. So ordered. Once again, thank you with such a distinguished panel here and testifying this morning, and even with kind of short notice. So thank you again, and the meeting stands adjourned.